Ooh, did you get that announcement? I got quite a loud announcement then. Right, well, hello. Hello, my name is Heather Henry. I'm a nurse and social entrepreneur, and I also have an honorary role with the University of Salford. Welcome to our Health Creation Academic Network. And today it is all about social businesses, why people running community businesses are good for well-being, and also around microfinance and how microfinance can support the well-being of people. We have three organisations represented today, all from Scotland. Professor Cam Donaldson, who I've been dying to get to speak at some health creation event for quite a long time. The Yunus Centre from the Yunus Centre for Social Business and Health. Noel Mathias from WEvolution. We'll do full intros in a bit. And Hugh and Roy from Lawn and Oban Healthy Options, who are new to me, so I'm dying to hear more. So it's being recorded and shared. And if you want to tweet, let's use the hashtag health creation, or one word. So the Health Creation Academic Network, just a couple of bits of information for those who it's your first time. It's about educating our future workforce. Principally, we're looking at undergraduates, but a couple of people have mentioned postgraduates in any discipline at all, so that they understand the causes of wellness rather than just the causes of illness. And we do that by inviting presentations like this from distinguished guests. And when I say distinguished guests, I also mean by that local people. It's interdisciplinary, it's multi-agency, and this meeting, it may well be international as well. So that's quite good. And we invite an interest from academics, practitioners, policymakers, and students themselves. And this is just our third meeting, and the recordings of the previous meetings, I'll send you the links through YouTube. Our first meeting was with Lord Nigel Crisp and the University of Salford to introduce us to the idea of health creation in the academic curriculum. And Nigel shared with us a lot of his work, that he's recently published a book around that, if you're interested, around health creation. And then our last meeting, Sarah, who's also joined us today, Sarah, talked about Sarah Whitehead from the Poverty Truth Commission and other organisations in Salford, talks principally around poverty and well-being, and that's been recorded as well. So enough of that. Let's go straight to our first speaker, who is Professor Cam Donaldson. He is the Yunus Chair and Distinguished Professor of Health Economics and the Yunus Centre for Social Business and Health at Glasgow Caledonian University. Take it away, Cam.
Okay, thanks, Heather. Just let me try and share my screen. It's actually telling me that I can't do that. One participant can share at a time. Here we go. Okay, can people see that? Is that? Yeah, good. So thanks, Heather. I mean, I too have been really keen to come to more Health Creation Academic Network meetings since attending the first two. And I just find the whole idea really exciting. So thanks for asking me to actually make a contribution, which I'll do for the next 20 minutes or so. It's going to largely be, from my perspective, a research perspective and a good news story, because our Yunus Centre has just celebrated its 10th anniversary, and despite all the challenges that are out there in the world at the moment, we've been feeling really quite positive about what we've managed to achieve over that 10-year period. And two of the main reasons for that are the partners with whom we work, and you're going to hear from a couple of those today, but also it's also to do with the institution in which we reside. So I just wanted to say a little bit about Glasgow Caledonian, the University for the Common Good. That's been in our DNA since we were formed as a College of Domestic Science in 1875 and was adopted into the university's coat of arms when we merged with Glasgow Polytechnic as a fully fledged university in 1993. And you see it here in the more colloquial language of for the common weal. But it didn't really form part of our strategic thinking, I would say, until the appointment of our current Vice Chancellor and Principal, Pamela Gillies, who you see in the middle of this set of photographs. She's the one that's really used that notion for the common good as the driving phrase for formulation of our university's institutional strategy. And it manifests itself in many ways, and I'll just give some quick examples here. One, of course, is in terms of who she has managed to persuade to be our university chancellors. Our last two are two of the world's leading humanitarians, Muhammad Yunus and Annie Lennox. And of course, I'll come back to Muhammad Yunus during the course of my talk. Yunus first came to our university in 2009, which I'll talk about, and our Yunus Centre came out of that interaction, but also he was interested in us helping him establish a nursing college in Bangladesh, which we did as a joint venture, and that recruits women from the Grameen Bank network, so people from in income terms, the lower echelons of society, and the idea is to educate them to Western standards of nurse education, create a network of proactive community nurses to work in Bangladesh, and that's been a huge success for us. We're also, as a university, we're the first university in Scotland to sign up to the United Nations Global Compact, and we're a global champion in the Principles for Responsible Management Education network. And through European Erasmus Plus funding, we've set up around the world various social innovation networks, which are to do with capacity building for social innovation, largely in academic settings. Common Good First is one based in Southern Africa, but we're also well connected locally in terms of Scottish Government consulting us with respect to the creation of their most recent social enterprise strategy. In research terms, we adopted the Sustainable Development Goals as the framework for our research strategy in 2017. And you can see here that we address that through these three overarching societal challenges. And the Yunus Centre is actually front and centre in terms of being one of our key university-approved thematic research centres addressing the goals. And you could even argue that the Yunus Centre was one of the drivers towards us actually adopting the SDGs as the driving force for our research framework. So that's the institution in which we reside, and I think that's important to point out, because I'm not sure we could have achieved all that we've achieved without being in such a positive university institutional environment. Coming back to Yunus, I think if I was recommending you, if you don't know much about Yunus and I was recommending a book to read, I would recommend that you read Banker to the Poor, which is basically his biography. And I've separated his incredible life out into three relevant phases here for purposes of today, where he starts as what you would say is a conventional economist, really, in academic and government settings. And then in 1976, he goes walkabout, if you like, and lends $27 of his own money to the inhabitants of a local village. It's all paid back, and that's the beginning then of Grameen Bank, which went through other phases of development and culminated in his receipt jointly with the bank of the Nobel Peace Prize in 2006. Alongside that, he began to develop this notion of socially purposeful business, or social business as he calls it. In Scotland and the rest of the UK, I think we would recognise that as social enterprise. The official definition in Scotland and Yunus's definition are very similar. He came to us in 2009 because he was asked to deliver the first Magnuson Lecture, named after Magnus Magnusson, who also had been a Chancellor at Glasgow Caledonian. And out of that came the Grameen Caledonian College of Nursing, as I've described, but also GCU's own Yunus Centre, which now sits within a network of 80 Yunus social business centres in academic settings around the world. And in 2010, he became Chancellor of our university. 2012, sorry. One of the attractions that I have with respect to Yunus is his counterintuitive thinking, and I think the group today will not be thinking that we're all counterintuitive thinkers, but I think that we maybe come up against some people who maybe would put us in that category. So in the context of microfinance, he talks about whatever the bankers did, I did the opposite. They lent to rich, I lent to poor. They made large loans, I made small. They lent to men, I would lend to women. He's talking about a particular cultural setting here, remember. The bankers was only lend if there was collateral, I did it without, so on and so forth. I took my bank to the village, so Grameen being the Bangla word for village, so it's a village bank. And that's the kind of thinking that I think we're applying to the whole notion of health creation. For me, coming to GCU in 2010 to sort of take on this challenge of building a research centre around the things that we'll talk about, there were one startling piece of information that was revealed about the city of Glasgow in that very same year. 28 years is the difference in male life expectancy between poorest and richest areas of the city of Glasgow, produced by the WHO, led by Michael Marmot in 2010. And you can see here also in the run-up to the Commonwealth Games hosted by Glasgow in 2014, 25% of boys born in the city were not expected to reach the age of 65. So that is alongside a world-class NHS by any international standards, world-class public health practices and research going on in the UK, and you could even argue that Glasgow is an exemplar of that. But it raises these questions about, well, what is it that kills people? And of course, it's different diseases, etc., illnesses that kill people, but the fact is that they're arising at differential rates in different communities. So the idea here of this slide is that we need to somehow get more upstream into people's communities to act on factors like disconnectedness, homelessness, hopelessness, lack of income, etc. So swimming upstream, if you like, to the causes of the causes and to try and act on them, this notion of global challenges but local solutions, which you'll hear a couple of great examples of shortly. And that's then what brought us to, in association again with Yunus. So one of only 3 people to have won the Nobel Peace Prize, the Congressional Gold Medal, the Presidential Medal of Freedom, and to have appeared in an episode of The Simpsons. And I'll leave you to ruminate on who the other 2 people are for later. So the idea is that we need vehicles then if we're going to act on these factors, these upstream factors that I've talked about. And in the Yunus Centre, we're talking about acting on that through notions of social enterprise and fair credit, or social enterprise driven fair credit. And our big idea, if you like, is that any social enterprise, through acting on aspects of social vulnerability, could be looked at as acting on social determinants of health and therefore be thought of as a complex community-based public health initiative. But how do you evaluate that? Well, most of our studies are based around what I portray, not my fellow researchers, but what I portray as quite a simplistic model, particularly coming from a health economics background, going from left to right on the page there, where there's some engagement with a social enterprise, which then acts on individual and community level factors, enhancing notions like social capital, cohesiveness, connectedness to improve health and well-being. And most of our studies in the Yunus Centre operate on that basic model, but as I say, our more sophisticated researchers coming from other disciplines as well would tend to produce, through their research and evidence, more complex versions of that basic approach with feedback loops, etc. But that's the basic thesis that tend to put forward. And what we're trying to do is to see, well, does social business, social enterprise, fair credit produce healthier, happier people than comparator organizations or comparator initiatives? And in the center, we have these three broad programs that you see at the top there. And these are the different types of methods listed underneath: economic evaluation, realist evaluation, etc., that we then employ to try and evidence that sort of simple conceptual framework that I've just shown. But I don't want to get into any of these particular methods in too much detail. Just as examples, some of our flagship projects, in 2014, the centre really got underway by us capturing two large grants. The first one there, a European Commission funded one that was looking at different ecosystems for social enterprise across 10 European countries. Really useful and important project. And we also got this large programme grant from two of our UK research councils on evidencing social business as a public health intervention. We know it in the Yunus Centre as common health, with 5 universities and several social enterprises engaged in that across Scotland. This is a map of common health, and you can see that it comprises 8 projects. They go from very basic sort of conceptual work, including a project led by a historian, through to then beginning to work with social enterprise stakeholders in the middle there on Focus 50 plus. Passage from India is the work that we conducted with Noel Matthias and his colleagues at WEvolution. And Growth at the Edge covers several social enterprises in the Highlands and Islands area to the northwest of Scotland. And then focusing more in later stages on much more quasi-experimental comparative work. And throughout that 5 years, we met every 6 months in a knowledge exchange forum with not just the project participants and partners, but a much wider set of stakeholders to help us interpret what we're doing, make suggestions for what else we could be doing, think of whether the results that we're coming up with can be generalized to elsewhere in the sector, etc. The key thing about Common Health was we engaged with 34 social enterprises across the whole of Scotland, and you can see WEvolution highlighted there from the work that we labelled Passage from India. But prior to that, one of the things you might have noticed was the Yunus Centre we're celebrating 10 years. We started in 2010. We didn't get these 2 big hits in terms of grants until 2014. So prior to that, PhD students were actually the mainstay of the centre. So we did some initial conceptualising and evidencing around with smaller projects around microfinance and health and social enterprise and health. But also, we then began to engage with some of our key partners. So WEvolution was started with this idea of sending 13 women to India to examine women's self-help groups there and bring those ideas back to the 6 communities around Glasgow from which these women came. And Noel and a couple of colleagues approached us about trying to generate some evidence around that. And you think, well, 13 women, this is a really fascinating project. That as researchers, we're usually dealing with big numbers, etc. But what we managed to do was to find an amazing anthropologist who was able to work in that context and follow the development of what became self-reliant groups in Scotland over what became in the end a period of 5 years through her PhD, and then through working on it as one of the common health projects. And then we have Healthy Options, started again, a small group of like-minded, motivated people taking over a local swimming pool. And you'll hear from Hugh and Roy as to how that then transpired. But what we, again, an organisation seeking influence with government, perhaps to an extent even resources from government, and government asking the conventional evidence-based questions. So we managed to create together a PhD studentship and employed a fantastic researcher called Francesca Callow, who I think might be on the call today. So hi, Francesca, and you're here to answer any difficult research questions about healthy options as we go forward. And Francesca conducted 3 separate studies to try and evaluate the success of healthy options in what we might say are conventional health research terms. And these are the types of findings that we get from those types of studies about people being positive in saying, in terms of articulating their enhanced accessibility to what are nevertheless informal settings, which is a good thing in terms of how they feel about being there, meeting people who not otherwise meet, enhancements in confidence, and then working through to new health creating activities emerging in direct health benefits, both physical and mental effects showing through as well. And then this important balance, I think, between sort of individual self-development, but support for that being within a broader ecosystem. Sometimes there's a tension created between the two, but actually each relies on the other. And it happens not just in those 2 projects that I've outlined. This is Focus 50 Plus, you'll have seen as one of the common health projects. So at that end of the age spectrum, these same effects are showing through. From Francesca's work, a slightly more formal presentation of a couple of conceptual frameworks. Active life, as you see on the left there, that's basically healthy options, but we anonymized that for the publication of Francesca's work. Moving Well as a public sector oriented organization in a neighboring but very similar town. And you can see that the key things about active life was it was able to perform at least as well as the more conventional public sector provider, but also to add some aspects. And the key thing there was this notion of a boundary spanner. The idea there is that it's an organization that is able to manage complexities better because it's more flexible, able to therefore sort of enhance this needs-based care model that is also articulated in that diagram. But you'll hear more about that from Roy and Hughes to these factors. A key aspect of our centre as well was to put this whole area on the academic map. And this is the Yunus Centre grew from about 3 people originally, including myself, to there are now almost 40 people, including PhD students within it, and these are most of those people there. Part of putting it on the map means also publishing in high quality journals, and again, this is just a selection of many of the outputs that the centre has produced in the formal sort of academic publishing setting over the years. So where now? I haven't really mentioned much about our work on microfinance, but through a series of studies that started in Glasgow, but we call them Glasgow, London and post-COVID diaries now, we've been able to look at the relationship between people's financial lives and their well-being in low-income communities. So we're targeting and working with, and so in many cases through microfinance organisations to recruit those people who are seldom heard. And in one of the studies, we particularly targeted people who already had multiple chronic health conditions. And these are the organisations with whom we've been working on that. The kind of method that we employ, the core method, is a financial diary method where you're basically working in quite an intense way with each respondent. Only 21 diarists in London, but we're working with them over a period of 6 months, and we're looking at every financial incoming and outgoing from that particular household. So it's very, very intensive work. And then we also have frequent interviews with the respondents with respect to life events, including impacts on their health and well-being. So very intensive methodology. And what it does is it helps you, rather than sort of classify someone as in poverty or not, in that sort of binary way that we might look at once a year. This is beginning to, what this does is it shows the instability in people's lives with respect to finance and other important factors that might be influencing their health and well-being, particularly often their mental health. We're also working with organisations targeting that target older men who, I think in many studies, those of you who are health researchers will know that in community settings, trying to recruit older men is often quite challenging, and we've done a lot of work with organisations like Scottish Men's Sheds Association to look at that, again, evaluate that or populate that conceptual framework, but in that particular setting of sheds for sustainable development. Our historian who worked on the Common Health programme of work has since developed the Social Enterprise Collection Scotland, working with our archiving centre at the university, and has developed projects funded by Scottish Government now on trying to communicate our heritage with respect to social enterprise in Scotland digitally and through comics. And once a year we also run the John Pearce Memorial Lecture, named after the well-known pioneer of community development, community business and social enterprise in Scotland throughout the 1980s and 90s, who left his collected body of literature around the subject to our archive centre. And then just recently, we, with the universities listed there and the Glasgow Centre for Population Health and 15 community organisations who I think are, in many respects, a lot like Healthy Options. We're doing this work across the UK called Common Health Assets. And again, it's trying to show, think about those organisations like Healthy Options as within what we might call an assets-based model of community and health development, and to evidence that. And you can see that this is a huge study starting on the left there with a programme theory that then gets developed through all the various research activities highlighted there in green, through to producing results not only on health and well-being, but through different modes of dissemination highlighted in the more kind of orange colour on the right-hand side there. So that's a 4-year project funded by National Institute for Health Research. So I know a lot of you will want to come to challenges and issues. So this is really just my final slide, Jean. I think it's best just to use it to set an agenda for discussion, because we've, despite what I've talked about as a really good news story and how we've developed, I think I hope you would think is a world-class health research centre around this topic or a particular aspect of health creation. We've come across these challenges too. There's often a view that Scotland's the best place to do social enterprise, particularly when we're talking with people from south of the border. You might think that academically, given what you've just heard, but we have a national strategy. We have strong overarching organisations who have been really supportive of us actually in the Yunus Centre. And we have more recently community empowerment legislation. But what's it really like on the ground? And that's why I think it's important to hear from Healthy Options and from WEvolution as well, if Noel's been able to join us. There are big sector challenges. Should the sector be held to the evidence standards of the sort that I've articulated? That's great for us as a Yunus Centre. It also allows us to partner with such organisations to draw in finance for more rigorous studies that neither of us would have been able to draw in otherwise. So that could be a good thing, but should it really be the same standard as new medical treatments, etc.? That's an interesting question, I think. Are we really translating from the evidence-based into government support? And again, it'd be great to hear what Roy and Hugh have got to say about that. There's also this notion of scaling up. Whenever people from business schools for example, listen to me talk, they talk about, well, how can we scale this up? How can we scale up Healthy Options, or how can we scale up WEvolution? And I think it's a naive concept, because in a sense, the notion that part of the success of the notion is its micro and community-based nature. So that might lead us to a different version of scaling up. Scaling up each entity itself could actually detract from what its particular advantages have been shown to be. And I know that training is important to you. I talked about the Green Caledonian College of Nursing with respect to training. That's even run as a social business, a social enterprise in Bangladesh. We have the largest nursing school in Scotland, but I would say that these notions are not coming through into formal training of nurses. We do, through being the University of the Common Good, have programs or modules that we instigate across the whole university, and that's a good thing. So we talk about social enterprise to nurses, etc., and other allied health professionals and other groups of students like engineers. But it's not, I would say, it's not really quite embedded as we, and I think some people on the call today would wish. And that's really all I wanted to say. Back to you, Heather. Are you to introduce Hugh
Yes.
and Roy and Noel?
Yes,
Stop sharing.
There we go. Now we can all see each other. Thank you so much, Cam. That was super. I think what I'd ask you to do, folks, is to consider, we'll hear the next two speakers, if we may, and then to put some either questions in the chat or have them ready to speak, and just put your hand up physically or with the little avatar, and we'll have questions towards the end. What I might do, because Noel's been running late, is Hugh, are you okay to talk next? And we'll just let Cam, let Noel settle in. Okay. Cam, do you want to do the intro rather than me? Because I'm new to Healthy Options, so just set the scene for us then. Yeah,
I suppose in a way I've kind of done it already. I mean, Hugh was the first person from Healthy Options to come and speak to us, although we've done more with Roy kind of in between times on various other aspects related to health creation as well. And it was, I mean, Hugh, I mean, it's really down to them really, because they spotted the Yunus Centre. And so in the early days of the centre, we were a bit of a magnet, because people thought, oh, I can't believe there's some people in an academic setting sort of thinking along these kind of lines. Let's just go and speak to them and see what would come out of it. But I think it was because, as I said, I think they got this, what I would view as a social enterprise going, but were then beginning to face different barriers and boundaries, questions being asked, which I think that we could work on together in partnership. And that's really where that's how it all started for us, and that's where Francesca's work came from. But Hugh's much better at articulating it than I am, I think.
Maybe not.
Okay. Do you want me to put your slides up?
You start, and I'll just prompt you each time I want to change.
Okay. And if anybody sees something that I can't while I'm doing this, just yell, people. It's a very informal network, this. Okay. Can you all see that?
Yeah. Okay, for those of you who don't know, Oban is a small town of about 10,000 of a population on the west coast of Scotland, approximately 90 miles northwest of Glasgow. And a beautiful place, very much a holiday town. And we, both Roy and I, Roy's a native and I'm an incomer from the 1970s. But you can see the photographs, the bottom left, you'll see our staff and some of the photographs that we take. Anyway, I'm going to run through a whole, maybe, I think it's about 10 slides, and I'll try and do that as quickly as possible and answer any questions you have afterwards. Thank you, Heather. Well, this, I can see this is going to work beautifully. So changing lives, that's what we do. We basically change lives, hundreds of them every year. So I'm going to run through why we started, how we do it, what we do, and talk lastly about the challenges and the opportunities that might present itself. When we started, we had a turnover of about 60,000 and 1.5 employees, and we're now over 200,000 a year. But as you can see, still very small. So, okay, let's see why. 40% of our community have one or more chronic medical conditions, and that's about 4,000 people in Oban. But it's not really just about unhealthy people. These are people who are our neighbours, our friends, with people we pass in the street. And it's really only the community that can actually do something about this. And the reality is, as we learned as we went into it, that most chronic conditions can be controlled, managed, or improved by becoming more physically active. And that happens in the community. You don't go to hospital to become more physically active, or indeed to be more healthy. So, and we realized that we had everything in the community to create this health. And latterly, the last couple of years, we have employed 2 specifically very highly qualified, highly motivated people who have increased our referral rates from about 150 a year up to 450. And that was in the year up to March 2020. And we'll not talk about too much about what's happened since then. Okay. So it didn't just start 10 years or so ago. Back in 1991, a group of us realised we had no sport. We were all family people. We had no sports facility, indoor sports facilities in the town at all. The nearest indoor facility was over 70 miles away. And we approached the council and we took over the swimming pool and started a community company in 1992, which now is known as Atlantis Leisure. And in the gap between 92 and 98, we built a £2.4 million sports centre. It was dead easy. There was nothing to happen in between 92 and 98. A whole load of work for everybody that was involved. After that, we were then developing the sports centre. And Roy and I got the opportunity of doing a research study for Carnegie UK Trust, the Rural Action Research Programme. And in the course of doing that, we had a discussion with a young lady, Pauline Jesperson, who was the head nurse and partner, still is the head nurse and partner at the local medical centre. And she waxed lyrical about what this sports centre could be doing to help people get healthy, not just for healthy people to exercise. After that programme, we started to think about this and say, should we get involved in this? Now, if you ask me today whether we should get involved with it, you might get a different answer. But at that time, it seemed like a good idea. So over the 2010 into 2011, we got the company organised, registered and whatnot. And we had our first clients in 2012. And we posted a pilot project report back in 2014. And here we are today, basically 10 years after we started, still struggling away at a different level, but doing what we regard as fantastic work and what we regard as being an exemplar organisation. So that's a brief. There's a load of talk could be done about the story between 1991 and 2021, but that's the basic of it. Thank you, Heather. So what we've got, and this is crucial for us, and we were a collaboration from the start, and we're still a collaboration. And you can see the 3 main organisations involved: Atlantis Leisure with the facilities, health professionals, the medical centre, the hospital people, a whole range of different health professionals, and ourselves. And the 40% sit and engaged across all 3. of these organisations. And down in the right-hand corner, this was a lesson that we learned doing the Carnegie study, that if the problems are in the community, the solutions are in the community. And anytime we're doing a talk and there is anybody from government or government department, that is always on our presentation somewhere, because that's the reality. If we're actually going to change health, it needs to happen at the community. Okay. This is an important wee slide for us, in that we developed this to demonstrate to a whole range of folk, from MSPs, senior health people. This is very simple. Health is the vertical line and quality of life is and we keep it very simple: well and unwell, poor and good. And the black lines going across, we could actually put names to some of these people. But basically, we all hope to stay in the top half and the right-hand side. But as we go through life, whether it's in young or old, sometimes we dip down and we recover. And sometimes when we get chronic conditions, we don't recover so well, and our quality of life goes down. So people that end up on the bottom left corner of this diagram are suffering. They've got trauma. It leads to hopelessness, as Cam mentioned. And our job is to take them from there and bring them across and up. And how high we can get them into the right-hand corner is really dependent on where they are and what they want to achieve. The bottom line I always mention, because this was a guy, Murdoch, and he taught us a lesson, because he said, you know, I'm not doing anything different out here than I might have done when I was getting physiotherapy up in the hospital and going on exercise machines up there. He says, but psychologically, it's hugely different because in the hospital, I'm a patient and I'm treated as a patient. Out here, going to Atlantis Leisure with health professional expertise, treating me and exercising and helping me, I'm just somebody else in the community that is trying to improve their quality of life. And that, I think, is very profound. But and if I knew I was talking purely to the accountants of the world, I'd be saying the bottom left-hand corner are high cost. These are people who are withdrawing from society's assets. And if we can get them across and up into the upper right-hand quadrant, and we've got some fantastic examples of some of the people who we've been able to help to do that, they become low cost and contributors. So when Cam's doing these evaluations and whatnot, to a certain extent, simple folk like us, that's all we need to show that this is a worthwhile exercise, both from the humanitarian side and from the national health side in cost terms. Okay, Heather. So the client starts off going to the health professional. This is the sort of route. It's all referred. They come through a referral route. The client goes to the health professional that says, I think healthy options. They refer them. We need to know a bit about, so this is where the contact with the health professionals come in. We need to know a bit more about their true health situation, their background, whatnot. And we spend about an hour in consultation with them, learning about them, learning about their expectations and what we can do and how best we can co-produce a program for them. So the idea is that they don't join a club. Healthy Options is not a club. Healthy Options is really an intensive route from getting from the health professional side back out into the community. And at the community, they can go in, they can join a gardening group, they can be doing all sorts of things. Atlantis, they can continue on with Atlantis. So it's really much a combined route through to better health. And you can see at the bottom, we are not conditions specific. We take people with all sorts of, and some of the people that we see, it is mind-blowing what they come in with and what they go. Our route probably takes on average about 12 12 weeks, and then they move on. Some of them are with us much longer, and some of them are shorter because they really just need that help and push to get back out into the community. And recently, within the last month, we've had discussions with the consultant at the hospital in Oban, who is working with long COVID, and is asking us what can we do to help with long COVID patients. So that's an interesting diversification just come up with in the last month or so. Okay, Heather. So Roy and I have done a bit of research over the last year to see what are our key elements that make us an exemplar organisation. And we have come up with 6 key elements. The main one, I would say, is assets. We have no physical assets, but we have people assets. Staff with the right skills, with the right knowledge, and with the right attitude. A board that are supportive and help to make things happen behind the scenes. The need, well, that's self-explanatory. There's 4,000 people with chronic conditions. We're not going to run out of people that need our help for a long time. Community, we see that in 2 separate ways. The health community, where we try and work through, we're dealing with the health people basically at all levels, from the National Clinical Director, the Chief Medical Officer from Scotland, etc. And our own local community. What other organisations can we link in with to help their people, and our people maybe go and volunteer for them? Innovation, this is where we always try to think of ourselves as thinking differently, seeking new ways, and how can we respond? Because people in the community, organisations are much more flexible than the statutory agencies. Thank goodness for that. Collaboration, we've spoken about health professionals and others out in the community. And then we go to our Achilles heel, financial stability. And the sad thing is there isn't any. We are vulnerable every year. Sitting here in June, we don't necessarily, I know we don't have enough money in the bank to run us through to the end of the financial year at the end of March next year. There is a great act of faith in all of us. Our finance comes from grants, basically. But we are now starting to change our model so that we become much more of a social enterprise. But one of the principles is that we started with and will maintain is that nobody will be disadvantaged in coming to healthy options because of their financial status. So the picture on the right is the front page of the report that Roy and I are producing, which is actually at the printers. And as I mentioned about different people coming to visit, we've had the Health Improvement Scotland people came, and you'll see the next couple of slides where we explain where we link with the health professionals, and they recognised the quote there, nowhere else in Scotland have we witnessed this level of integration between NHS and third sector in scale and depth. And then Professor Graham Ellis, who is the advisor to the Chief Medical Officer for Frailty in Scotland, and he has been to see us several times. And in the report, he gives a 3/4 page quote about us. But the opening thing is from what he saw in Oban, taking what we knew in theory and putting it into practice. It's what we need to replicate across Scotland. Okay, the next slide is a very messy one. So I'm going to jump to that. That's the full sort of diagram of what we have created with the NHS, Oban Living Well Support Services. Just go to the next slide, Heather, and we'll deal with it in much simpler way. So down at the bottom in the red area, this is where the Lawn Medical Centre health professionals working in a multidisciplinary team, not only involving health, but social care, carers, pharmacy, physio, and basically anybody else that working in and around the community that can help with a specific client or patient. So what they're doing, instead of just looking at the person in terms of what diseases, what problems have they got, they provide a holistic, anticipatory care to patients with complex conditions. But these are people who are fairly frail. The reablement in the orange is one that is physiotherapy led, but is the exercise work is delivered by our exercise professional from ourselves at Healthy Options. And this is home based. So the physio go in, decide that this person is suitable, do a bit of assessment. We go in for 6 to 10 weeks, a couple of times a week, giving them exercise, appropriate exercise, and so that they don't end up getting down into the red box. And then the yellow section is Healthy Options. And we lead on that, but we have this professional advice available from the health professionals, whether it's in the doctor's surgery or up in the hospital. So these are community-based programs for chronic conditions. You can see the numbers escalate from 400 at the bottom to 600 to 4,000. And we see that there should be a top level by creating health, preventing this deterioration. So we don't need a Healthy Options. We don't need people at reablement, and we certainly don't want, as somebody who's certainly in the upper echelons of age, we certainly don't want to see people down in the red area. So everybody should be involved in that. We have started, and Roy was leading on this, the Oban Healthy Living Town, and there is a committee, but everybody's very busy and it hasn't really taken off to the extent that we would like it to. So my last slide is the challenge and the opportunity. And it's really about thinking differently. How do we create health through community-based, community-led health improvement system? It has to have certain characteristics, we believe. It has to be designed in full collaboration with the NHS and health professionals, but it can't only be left to the NHS and health professionals. But it has to, because it has to empower and support individuals and communities to take responsibility to keep healthy. It's more effective than current practices, and it reduces reliance on NHS resources and budgets. And it can be implemented in rural and or urban areas and can be evaluated. It's financially sustainable with NHS budgets and the procurement systems, because the procurement systems operated within the statutory agencies work against small organisations. And it's the small organisations working in the community that know the issues in the community. So they are the ones that can help solve the problems in their community, because each community is different. Each community has got different assets. And the existing procurement systems are a deterrent. And it has to remain rooted in the communities. And you know, I haven't put this on a slide, but in 2020, April, Public Health in Scotland put out changes to how they are going to operate in the future. And they identified 3 major challenges: Scotland's relative poor health, significant and persistent inequalities in health outcomes in Scotland, and unsustainable pressures on health and social care services. And to that end, they agreed on 6 priorities. And they just run through them very quickly. Scotland, where we live vibrant, healthy and safe places and communities, where we flourish in our early years, where we have good mental well-being, where we reduce the harm of alcohol, tobacco and drugs, where we have a sustainable, inclusive economy, and where we eat well, have a healthy weight and physical active. Now, at this point, I should probably ask and say, how many people, show of hands for everybody that thinks that's going to be done within NHS establishments? No, it's not. And it has to be happening in the community. And there are, I believe, great opportunities for CAM and the Yunus Centre in helping drive that agenda forward, because we got great benefit from our contact with the Yunus Centre and with Francesco doing her PhD. It was interesting in that, and it was useful for us because we were then engaged with people who came from a different perspective. But we gained confidence from what they were doing. We could see that we were relevant, not necessarily just in our own local town, but that we were relevant on a national scale. And it gave us access to that perspective and to different networks. In fact, obviously, if we hadn't had that engagement, we wouldn't be speaking to you folk today. And certainly we would encourage other small organisations to be involved and engage, to get more exposure, to have discussion, be examined, supported and evaluated. So certainly we've had major benefit from the association with CAM, and I think from our experience there is useful avenues that can continue, and certainly we are happy to have our organisation evaluated. And part of the report that we're about to publish, it will be on our website this month, is work that one of our directors, a GP locally, and somebody from the one of the departments, auditing departments of the NHS have produced, where it talks about investment, not a cost. So that may well be of interest to folk as well. Okay, Heather, that's me. Thank you.
Thanks so much, Hugh. I love that as a checklist at the end. So time's ticking. So again, just have a think about your questions. Just a little reminder that we are interdisciplinary and work at all levels. So if you're phrasing a question, please don't use any abbreviations, just use plain language so we all understand each other. You see that the presenters have done that beautifully. So I'm going to, without delay, I'm going to hand over to Noel. I've known Noel several years, since Lankelly Chase Foundation, which is a foundation supporting serious and multiple disadvantaged populations, raved about WEvolution. And so I got on a train from Manchester to Glasgow to go and have a look at them. And I think I'll hand over to Noel, and he can explain a little more about his theory of change. Noel.
Thanks, Heather, and it's good to be here with you folks. It's getting increasingly disconcerting, isn't it, to do this stuff on Zoom, because more and more people have started shutting down their cameras. So we've started speaking to screens, and now we are learning to speak to blank screens. At about 2:15ish, I think Heather called me saying, "Noel, where are you? Aren't you supposed to be here doing a presentation?" And I was out there changing a car tire. So I left all that, came rushing here. It's good to be here, and certainly listening to Cam and then to Hugh. What we are attempting at WEvolution, first of all, is an unfinished story. It sounds glamorous on most days, but is full of human struggle on the rest. But it is about probably just human stories of struggle, of being in control and of out of control. What we are attempting is a relational approach and seeing how it could impact human development, especially around health and economic enterprise. And so at two levels, what it does is it does away with the interventionist and a treatment strategy, where if somebody has a mental health issue, there's a mental health charity dealing with it, for instance, or if there's a debt issue, there's a debt agency dealing with it. And in its place, what we've tried to create is what we call a context or a space where people create solutions for themselves and for each other. So this is less about service provision and more about a space for creating solutions, many of them very local, very microcosmic. And at another level, probably the cultural level, what we are trying to do is recover the we in a place that is full of I. And I'll explain how we do that through a visual graphic of the approach. Heather, am I allowed to share the screen?
I think so, but just let me know if you struggle.
I think I'm struggling, but
okay. Let me just find you then. Noel. There we are. Chief Troublemaker, that's you. There we go.
Okay, thank you, Heather. Over several years, starting off certainly with the Glasgow Caledonian University, especially the Yunus Centre where Cam was, and then later through a social scientist, we've collaborated with the SRGs and we've built up what we are calling this the relational approach, a theory of change. And the women themselves have come up with this whole graphic and the changes in there. They are saying that there are a number of women like them in Scotland. We've sort of estimated about 330,000 women in Scotland who experience social and economic stress at various sort of levels. In terms of coping, those who have family and friends as connections, the two key pillars of health, they sort of cope with the stress quite well. But a number of people who don't have that in their lives experience a sense of shame and disconnection from potential help from agencies who are out there, and we tend to call them hard to reach populations often. But there is a particular nature of experience there, and which does mean that several things happen almost all at once. Increased isolation, there is less social connections, but very importantly, the cognitive bandwidth to deal with life's issues starts shrinking more and more. And there are issues like money, children, all of that starts putting and piling pressure. And what you find is people inevitably feeling stuck, especially women, because of the particular roles that they carry in lives and in the families and in the society. Now, what happens at this stage for the voluntary sector or the third sector or any sector that's trying to sort out issues or problems is that we start defining these categories of people as clients or beneficiaries, or as they become caseworks in the sort of caseworker files. And these are people that are meant to be treated because they have an issue of sorts. And all of our services are designed to treat or fix the problems that people experience. What happens when they connect in an SRG or a self-reliant group is very ordinary stuff like savings. One of the first things they do is start saving 50 pence or £1 a week. They use this savings to help each other in times of crisis. There is trust built up. There is ordinary conversations, getting in touch on WhatsApp, Facebook. People discover new friends, and you start people having fierce and sort of lasting friendships over a period of time. What we have found that within this space, over a long period of time, people start experiencing a different mindset about the choices they start making. They have people to check in with about the choices they make, the problems they experience. They start making smarter decisions. And what we find is that mental bandwidth has started to expand. They still make mistakes, they still feel out of control, but the periods of being in control start to become longer and longer. And there is the potential to get unstuck, to take more control of their lives and become more enterprising. And within that space, we find inevitably people starting up some informal income generating activities. They start thinking like an entrepreneur, and a fair few of them go on to start up businesses. Currently, we have about 12 of them who've gone on to become fully self-employed, and there are another 60 micro businesses at various levels, some of them earning money already. We have businesses like a co-working space, a well-being center, a cake making business, a laundrette, a chocolate making business. And remember, these are all coming from women who would have initially felt stuck and would have been treated because they had a problem, either because of abuse or single parents or debt, for example. What SRGs do is to treat them as unexpected entrepreneurs. Within this, certainly the pressures don't change. Everything remains the same. But what they find is they're able to cope with all of that so much more. And within WEvolution, our role, therefore, is not so much to change life for people. It is simply to provide a few support elements like group finances, helping them to understand where they might bank their money, for instance. Would it be PayPal pool savings accounts? Would it be RBS? And then negotiating with these agencies to do the savings, to look at what data looks like, not for the agency, but also what could it look like if they were to own the data. And so a number of those elements that we help them with, including business advice. And our job, therefore, is simply to make the space so that people in it could create the solutions to flourish. And that's sort of, in a nutshell, is the SRG approach. It's not rocket science. It's probably the simplest thing in the world to do, and yet we make it so complex. How did we pick up this approach? 10 years back, this is in fact the 10th anniversary of that trip. 13 women from Glasgow, from about 7 disadvantaged locations, traveled to India to explore a similar phenomenon taking place there, which started in 1980s with a few women and has now become a movement or several movements of about 12 million of these groups, with over 100 million people, especially women and their families, involved in this. And the women from Glasgow learned from this experiment and said, we want to take it back to Glasgow and start working on these. Because these were informal groups of community members. They were not legal entities. They didn't take funding. They didn't have a leadership structure. They had none of the paraphernalia that we have built up around delivering services. What they were doing was simply creating the space to make solutions happen for themselves, or creating them for themselves. And what grew as a tiny sort of that shoot here in Glasgow has now become a movement across several parts of the UK. I'm very pleased to see Joyce here and Sarah there hiding behind the screen, who are very actively involved in helping grow this movement in Manchester. And there are people in Wales, in Rotterdam, in Netherlands, and there are about 140 odd groups here in the UK. These are not perfect groups. They're not made up of robots. Yeah, I always say that one of the best things about SRGs is that they are messy. They're very fragile, but they are absolutely magical. And that's something very hard to comprehend for the funders or even for the government or for a statutory agency. For us, one of our biggest challenge is the fact that funders or the government or statutory agencies would want to see very clear tick boxes about, is this about economics or is this about human connections? So I get a funder who said to me 3 weeks back, Noel, it seems to me this is about economics, connections, health, everything. Why don't you just stick to connections? It will make our life easier to give you funding. And you have the government, for example, that says, no, we can't really fit WEvolution within our structures. We don't know whether you are a social enterprise Or are you delivering public health initiatives? Or are you about community empowerment? Or are you about community regeneration? So our challenge is trying to fit within the boxes created by an external agency. And that's probably about language as much as about a cultural mindset where we have siloed a human being into fixable parts. And that's what we are trying to rebel against, to create this whole movement where people, very ordinary people, yet doing extraordinary stuff over longer and longer periods of time and staying in control. I'm going to stop there, Heather. Uh,
Thank you so much. Okay, that's a huge amount of information, and thank you to all of our presenters. And we also have resources within the meeting, Joyce, Sarah, Roy, also here to answer questions. And so, do we have any initial questions for our speakers, or shall I allow you a space while I ask mine? Because you know I can talk for England, daughter of a hairdresser and a salesman here. So my question to the three presenters is, so what is your one top tip for those undergraduates who are preparing to come and work with communities? What is it that you would want them to know or believe or understand? What is it? Just unmute yourself, speakers, and just give us a shout.
Heather, if I can jump in there, Heather, I think the one biggest thing is to realise that the latent power of a community, the resources that are there, and the willingness and enthusiasm and the skills that are in the community to make a change and make a difference, and just and to be able to tap into that, and that involves collaboration. It involves leadership and support behind that to allow that to flourish. It won't come just from a health professional or a student if it's a one-way dialogue, or if it's a community saying to health professionals, you need to do this. It's really working in collaboration from the start. But actually just acknowledging and being aware that the community is a resource for health and well-being, and to allow roots into that place for discussion and where things can happen.
That's brilliant. You know, I believe that. Well, as you know, I practice that for some of you who actually know me, giving the community that sense of purpose, hope, mastery, and control. This is what we're talking about with health creation. We aren't talking about prevention, although Healthy Options does that as well, I think. Anybody else? Cam, what do you reckon? What is it that we should be telling those students?
I think from a research perspective, it's about listening, really. So not going in with, you know, whatever a professional hat on or a professional researcher's hat on to, in a sense, try and prescribe how things should be done. That and I think it relates partly to what Roy's just said, that the answers will come, and then you have to then frame the research around that, and that, of course, the difficulty then is that what's coming might not be what you see as your particular specialism, but then collaboration at the university end is what's then important, in the sense of having an inter and multidisciplinary outfit that can then address the questions as they arise. So in the case of WEvolution, the main researcher there was an anthropologist from the Yunus Centre, which is 1,000,000 miles away from where I see myself as a health economist. But no one else could have done that work. But we also have geographers, we have a historian, as I've said, and lots of other disciplines in the Yunus Centre that allow us to address the questions as they arise and are articulated by the community and the entities that they design for themselves.
Fabulous. What do you reckon, Noel?
I suppose the one thing that has been in my mind for a long time when it comes to health is that we cannot do health in a vacuum. That there are multiple forces bearing down upon the individual, and that affects both the mental side and also the physical side of it. And we sort of know that intellectually, and I think we study that. Uh, but there is something about I was speaking to somebody the other day, and they are doing some work around racial injustice, and how that is coming onto sort of radar of a lot of people, and the problem with racial injustice and why it wasn't paid much attention was that people were busy doing community building. Ironic that we did community building but didn't think racial justice was part of community building. So there is something about actually being aware of what else is happening around that human being or within the society, because within the studies we do, we could become pretty sort of myopic and have a tunnel vision, because I am going to specialize in this and that's my sort of job. There is something more to a human being and to a collection of human beings that happens. And I think to have that, a bit more of that holistic element, could be very crucial and probably could just make that little difference to the person you tend to spend time with or care for.
Thank you very much. Hugh, do you want to say something?
Not really. I think that Roy has answered very adequately. I think everybody else has as well. And I think that maybe people going into communities and working with people need to develop trust. And you can only do that by talking a common language and realizing that people have a different paradigm from them. Their world is different. But so there's no point in trying to communicate that a different view has to emerge rather than being forced. So I think trust and trust is a very tender thing. It's difficult to produce and very easy to break. But I think until people trust one another, you're actually not going to get that far.
Yeah, I think it's a lot about trust and relationships. Telly.
Yes, I'd just like to say thank you for the presenters and to identify some key common themes. Firstly, in relation to the anthropologist's contribution, traditionally anthropologists are known to be studying people from faraway places. I like to recommend the work of anthropologist who works for the Times. I've forgotten her name at the moment. It will come back to me. And the point I want to make in relation to that is the importance of taking a multidisciplinary approach to addressing these issues. These are the common themes for the three presenters. And also, when we're talking about social capital, which was Dom's presentation, I want to link the notion of social capital in relation to bonding and collectiveness to the comment Nola just made about the importance of taking account of the racial dimension of it. And also, again, the common theme in all the three presentations is relation to power and material resources, in that as with the SRG group, the importance of material resources, funding, with Hugh's presentation, the importance of funding, and with Cam's presentation, funding to get for research. So that's a key theme for me, that when we are talking about health creation, we need to take account the relation to power and material resources to be able to make effective changes. And the theory of change I was presented at the micro level clearly also relates to the structural level.
Just explain that a little bit more.
Well, the structure level, the self-reliant group is essentially about interpersonal relationship, group group support, but at the end of the day, it has to be within the structural context.
Yeah, gotcha. That's really very helpful. We can see the power discussion is carrying on in the chat. We have this conversation every time about nurses regulation organization, and some of this is about how we see the world, what our paradigms are, how we actually make sense. Because with a lot of those presentations, it was about trying to find partners who understood that health is created within the community, not within service provision, within statutory services. Any other comments? I know Joyce and Sarah are also here. If you want to say anything, Joyce or Sarah, about what you think, because I know that you've had a recent conversation following your presentation with the University of Salford to see, you know, how can we start to talk differently to our students so that they can break out of their sort of mental channels about how they view and work with community. Do you want to say anything, or anybody?
I mean, I think it's really important that what you're doing in relation to the teaching new nurses, and that change will not just happen from the top down. Change will happen from the bottom up, and sometimes it's more powerful than the top down. And you know, the government say and do good things, policies can be right, but our experience has been over 30 years has been that the policy might be right, but actually implementing policy, getting down to the work on the ground just doesn't happen. And if it happens over long periods of time. Whereas stuff being changed, changing people's behavior, getting them to think and do things differently, then changes attitude. So if nurses come in with a different viewpoint and a different understanding of their role and what the community can do for them, they can start influencing, you know, manage your boss upwards, if you like. So I think that's quite a powerful way. It has to happen at all levels. So starting at the bottom and getting people educated. We bring people that are trainee doctors coming to the medical centre. They come to us for half a day or a day and learn. And what we call invariably what we call the light bulb moment, because they've been trained at university to think in a certain way, and this is what medical practice is, etc., etc. And they come to us and think, oh, this is different. The light bulb goes on. Now, that's only one day's exposure. But if they start thinking a little bit different because of that one day, and when they become GPs or health professionals in other areas, they might start thinking about how about us doing things slightly differently?
Yes, absolutely. I don't know whether you want to say more, Telly, about social work, because I think that's your background, isn't it? And you know, your experience of working with social workers and educating future social workers around these issues. So I think I would have thought that this is more natural to social work, but I might be wrong.
Well, actually, my background traverses community development, youth and social work training and education. Unfortunately, social work now in the historically from the 70s, 80s and possibly early 90s, there was a movement to see social work within the community context, whereas now it's totally different. It's about clienting. And this is the consequences of liberalism and seeing the Hugh's presentation was, the starting point was seeing people who need support have become clients rather than taking a much more transformative transformative approach, which Noel is essentially proposing or working with.
Yeah.
So unfortunately, I don't, in terms of the delivery of social work at the moment, is countercultural to what we're engaged here.
Right. It sounds like similar things to what's happened in nursing. Anne, I know you wanted to say something about men's sheds and SRGs. So do you want to, does everybody know what a men's shed is, by the way? Because I'm conscious that Mark is on the other side of the pond and might not know. It's basically where men's sheds associations have been going for a while. I think they originated in Australia, if I'm correct. I've been involved in one in Salford, and it's where men get together in sheds for purposeful activities where the intention is more around the social components of creating health rather than anything else. So if you don't know what men's sheds are, Anne, do you want to add in?
Oh, thanks, Heather. It's Anne Taylor here from Parish Nursing Ministries UK. Yeah, I was just reflecting really that we started with those statistics around men, and then we talked very much about women's health, and I think those sort of making space can be very, very difficult, and perhaps more difficult for men, and to address men's health. And also I was just quite interested in that what looked like a very physical physical health focus for healthy options, but clearly was having an effect on people's well-being, so a much more holistic sense of health and well-being, and whether healthy options had an intentional focus on holistic health, or whether that was almost a byproduct of focusing on people's physical health. So a couple of rambling thoughts there, but it's been absolutely fascinating discussion. And I think the pressures, Kelly, you were describing there on social work are very similar for nursing, that the pressures of the health service to actually treat the injuries, treat the disease, means that we haven't got the time to go upriver and sort out the preventative side. And what we're describing here is very telling. I think that Hugh mentioned those years of absolutely heart-aching work that it takes to even get to the point where you can produce a leisure centre, let alone go on to do the health promotion work and the fabulous work you're now able to do. It's a huge amount of time, and still with that financial insecurity around it as well, it is very, very difficult then to make the case for nurses to step perhaps out of security of the NHS to think of health promotion, health creation. So lots of rambling. You made me think an awful lot, Heather, there, but I'm aware that other people have got their hands up.
Okay, yeah. Well, it's also about making some introductions here. So please do share your email addresses if you feel comfortable, and do make connections. Judy, then Roy. I'm going to take us slightly over because we did start slightly late. I've been a terrible chair, I think, for timekeeping. But let's take those last two, and then I'll wrap up.
Okay, it was just a real quick reflection, really, about the bit that was going on in the chat about the way in which nursing tends to have been developed, and the way in which it's being regulated, that actually tends to close down a conversation rather than open it up. And I'm very thankful that I went on and did my health visiting, because I was around when Sarah Cowley, etc., were doing all of that upstream working and writing some amazing academic articles about about upstream working, and really looking to see where the need was, and creating something that was effectively bespoke for the community in which you worked. And I was also fortunate enough to work within Sure Start in a very deprived area of Ipswich, where there was a high percentage of Pakistani, South Bangladeshi families. So we were kind of, but we were able to mix and mingle families, and actually enable sort of cultural learning, as well as the recognition of shared need across cultural boundaries in challenges in parenting and things like this. And I think I think I feel as if I've only ever really been able to influence small scale, but something that I did that which was in response to a QOF, the QOF introduction of
Policy and Outcomes Framework for Doctors, yeah, in GPs, yep.
GP land, where they suddenly required us to begin asking questions about mental well-being for patients with long-term conditions. So effectively, it was a low-level screening for depression and anxiety. And I kept going back to the GPs and saying, most of these people will be subtherapeutic. They won't need referred through to mental health services. We've got very little to offer them. You know, isn't there a problem in us kind of like identifying things if we haven't got something that we can direct them through all the time to actually provide that support? And a project that I set up at that time was called Quality Zone, and we actually delivered yoga sessions within the surgery to actually engage people that wouldn't have gone to the gym, but actually later went to the gym to carry on attending these yoga sessions to improve their balance, their flexibility, and their mental well-being. So although it was on a very small scale, it was something that kind of like we worked and we sold the idea and engaged people that wouldn't otherwise have, that certainly weren't interested in the passport to health scheme that was going at the time, which was if you need to get fit, here's a gym membership for you for so many weeks. That was being sponsored by the or whatever they were calling them at the time, not CCGs, PCTs.
Primary care trusts. Yeah, yeah. Fantastic. If you do have any references that you would like to share, please do email them to me. I am creating a sort of database of research and evidence and things like that. Roy.
Yeah, it was really on the point about nurses and health professionals and undergraduates being exposed to the community and community organisations. And I think it's what I was wanting to say, this isn't something that's hypothetical. And how do we do this? We have absolutely everything available to make this happen. Now we have the skills and expertise within numerous health organisations and community organisations across the UK doing fantastic stuff. So the technical expertise, the health expertise, the business models are there, which can be explained and exposed to the undergraduates. And we have superb organisations like the Social Enterprise Academy and Glasgow Galley itself, because it was involved in the Silken project, which is linking academics and practitioners. And so there is the vehicles are there, the knowledge is there, the ability is there. Some of the programs are there as well, understanding social enterprise, understanding communities. That's there and it can happen. Yeah. So it's not something which is weird and out there and how do we go about it? No, it can happen.
I absolutely agree with you, and I agree with Hugh that actually if we go from the bottom up, which seems to be happening with this network, and see if we can come together. Universities are wanting to change their curriculum. Community organisations are wanting to share what it is that they need to know, and then eventually, for my nursing colleagues, we will have that conversation with the Nursing and Midwifery Council and all the other regulators to say, please change your code, please change your guidelines for professional education. That is my great hope. I am going to wrap up because we are over. I want to thank all of our speakers and yourselves today, because you all are assets. I do have 2 more events planned already. So the first one is on the 13th of July at 10 AM with Professor Donna Hall, the chairman of New Local, extremely well-known speaker, who is going to talk from this perspective. New Local is an organisation that supports local government and through that local community development. So she's going to speak that morning about her view about what needs to change in terms of how we educate the people who will be going out to work in our communities. I expect there'll be no punches pulled in that discussion. And then in September, date to be arranged, we have Neil Baldwin, who Toby Jones portrayed in the film Marvellous, who became the kit man for Stoke City Football Club, who overcame what others perceived as his limitations. I think in medical model we call it learning disability, but actually didn't see any of those things as a disadvantage, and has gone on to have a very successful life. And he comes along with Malcolm, his friend, who is portrayed in the film. And Malcolm's a friend of mine. He's the chair of the Football Supporters Association. That's probably where you'll know him from. And we'll probably do it at Keele University, I think, where Neil has a voluntary role there. And I think we'll have a little watch party of the film before the event, so that we're all on the same page as to where Neil's coming from. If you do have suggestions about what topics we'd like to cover, there are some coming from that. Coming from you today, then do get in touch. Are you all happy to share your slides through Eventbrite and things like that, speakers? If you're not, tell me again. And you've got the recording again here, because there's a lot of information there from you guys. Thank you so much. The thanks are coming in. If you want to save the chat, it's those 3 little dots on the right hand side, and click on that and you can save the chat yourself if you wish to. Other than that, I shall see you on July the 13th at 10 o'clock with Donna. Thank you all so very much.
Thank you. Bye.
Bye, Heather. Bye.
Bye.
Bye, everyone.
Thank you. Bye.
Bye.